Okay, this is going to be an exciting session because this is sharing of experiences of different programs and projects across the country. We begin this session by inviting Dr. Parag Shah. Parag, yeah, so he's going to talk to us about the new classification. Parag has been one of two Indians who was selected for the ICROP 3 classification, and I think can't be anyone better to tell us about them.
So thank you very much for this invitation. And so I'll be talking on what is new in the new ICROP classification. So before going to that, just a quick recap of the history, that it was first published in 1984, where the stages 1, 2, 3 were given with plus disease. Second edition came in 87, when the detachment was subclassified into 4A, 4B, and 5. And 2005, it was revisited again, where the terms of pre, plus, and aggressive posterior ROP was introduced. So then the 2021, the ICROP 3 classification. So what is new? There are a number of differences which they have been added, and I'll quickly go through one by one as fast as I can to cover all these things. So coming to the addition of the first is a posterior zone 2. Now we know there are 3 zones, zone 1, zone 2, and zone 3. And the ICROP 3, they added a posterior zone 2, which is around 2 disc diameters from the edge of zone 1. And why is that? Because we know that a disease in posterior zone 2 behaves like a zone 1. So it's actually a little potentially worrisome disease. So this will give a clinician a better idea that if it's a posterior zone 2 eyelash, we should have a more frequent follow-up than anterior zone 2 disease. The term notch. Traditionally, we've been told that we have to define ROP by the posterior most zone. So when we say a zone 1 disease, we always get scared. But sometimes the zone 1 is actually just a 1 or 2 clock hours, where another 10 to 11 clock hours is in zone 2. So this was identified by the ICROP 3, and they say if there's only a notch which is defining as a zone 1 disease, then a modifier zone 1 secondary to notch should be added. So it shows a little less worrisome disease than compared to a disease where the entire zone, the disease is in zone 1. Now plus, we know there is pre-plus, normal, pre-plus, plus, but the ICROP 3, they knew that in real scenario, real world, there is no consensus between anyone, and it's a spectrum. So they gave a continuous spectrum of images starting from normal to plus, and in between all the pre-plus images. And you can see they were given to all the committee members. Everybody agreed that this is normal. Everybody agreed this is plus, but even the ROP experts did not agree in these images. And now, of course, we know that the ICROP 3 has come out with a score called the P score now, where the 9 images were given, and now you can add that also as a part of your plus. That is a P1 or P2, P9. And the plus should be determined within zone 1 and not in the narrow field around the disc, which was traditionally given, and not number of quadrants, so 1 or 2 clock hours. It can be in any number of quadrants. As long as it is zone 1, it can put as plus disease. Now stage 5, we know total detachment, and depending on the configuration on the ultrasound, it can be an open funnel or a narrow funnel or a closed funnel. But how do you differentiate clinically without an ultrasound? So the ICROP 3 gave the 3 subcategories as 5A, 5B, and 5C. Where 5A, if you see the disc, it's obviously a open funnel detachment. If you don't see a disc, like you see a retrolental fibrovascular membrane, then it's a closed funnel detachment. And there are 5C is with the even severe form with the anterior segment changes. Aggressive posterior ROP was given in the year 2005 when they revisited, and they had defined it happens only in the tiniest babies. But during the same time, we showed that in our scenario, it can happen even in bigger babies. In fact, very big babies got this ROP, the aggressive posterior ROP, and subsequently many people, I'm sure many people have experienced it also. And this was recognized by the ICROP 3, and then they decided to drop the word posterior and to make it the name as a new name as the aggressive ROP. And just to recognize it can happen in larger preterm babies in the regions of the world with limited resources, which is a little sort of controversial. So these are the AP ROP. I'm sure iROP now everybody sees this, especially from the outbound of the rural babies, where you see the vessels actually going in the periphery and they are actually sclerosed because of oxygen, I would say. Now, with the anti-VEGF era, there was a thing that there is a regression and progression of the disease happening more often than in the laser treatment. So this was recognized, and they gave more stress on regression and reactivation. So when you give an anti-VEGF, the disease regresses, but when it does not regress fully, it's an incomplete regression, and there's a lingering peripheral avascular retina. So you should put a post anti-VEGF a regression as a PAR in which zone and the extent of clock hours. And we know that when the half-life goes off, there's a reactivation of the disease. So when the reactivation happens, you have to put the modifier called reactivated stage 2. So then the clinician will know that this was a case which was a treatable ROP, it was given anti-VEGF, it went down, but now it is reactivated. So it's a reactivated stage 2. And of course, we added the OCT and the FFA images also just were introduced. And the main clinical use of OCT is to differentiate between a subtle 4A from 4B. Apart from that, there is not much as of now. So just going a little step ahead, that is everything new in iROP? Well, I don't think so. And some things, especially this, is a disease which is actually haunting us from the past, from the dark ages. And I'll just tell you how it is from the past. So this is an image taken from the AGO 1953 article. And this was they tried to classify retroretinal fibroplasia in this was 3 decades before the iROP 1. And you see this is stage 1. And they have written that dilatation, tortuosity of retinal vessels, hemorrhages may or may not be noted, and early neovascularization, especially in the extreme periphery of the visible retina, may be present. And this is the latest iROP 3 with one of our images, and you can see the similarity between the two images, and not only the similarity but even the wordings. And now we say that aggressive disease may occur beyond the posterior retina, which was already seen in the 1950s. So actually, this is nothing, but this is what has come haunting from us from the past. It's like the mummy returns. And we have come up with this recent publication called Retinopathy of Prematurity Comes Full Circle. After 70 years, the same disease is coming. And this was published in the journal, neonatology journal called ADC-FNN, which is the official journal of the Royal College of Pediatricians. And the co-authors were Alistair Fielder and Graham Quinn, who were the other two main pillars of iROP 3. Graham Quinn actually is the only member from the first iROP 3, and Brian Darlow and Neil Marlowe are sort of the rock stars of neonatology. And collectively all agree that this is what is happening. This is the past which has come to haunt us in the developing world. And this image also shows, this is from one of our images, where the vessels are actually grown, but after a while it started regressing because of oxygen toxicity. The same thing which was shown by the previous speakers on the OIR model. So it actually happens in humans also. So how come the first epidemic ended and why is it come back? There's a simple reason for that. So this is a landmark article way back in 1956 by Kinsey, which showed that the retroretinal fibroplasia and the oxygen use is toxic for the retina. And that time, let me tell you, there was no saturation. Oxygen saturation came way back, way later in 1972s. So that time there was only the oxygen concentration. And these are the conclusion that they said that for all practical persons, there is no concentration of oxygen excess that of air. That is, any concentration more than 21% has the risk of baby getting ROP. Secondly, it should never exceed 40%. 40% was the cutoff given in 1956. And there was a widespread publicity given to the various medical and lay agencies that time. And that is how it ended. And if you have to give the oxygen, the concentration should be as low as possible. But now we have the saturation. It is easier to it's easier to monitor it. It's easier to measure it. It may sound the same. It has the same unit also, but it's totally different. And I'll tell you why. The concentration is something which we have totally forgotten now. We just concentrate on the saturation, and we don't see how much of concentration of the oxygen is being given. This is the oxygen dissociation curve. How much of oxygen you give, the saturation is never going to go more than 100%. 100% is the peak. But if the concentration of the oxygen increases, the PaO2 is the partial arterial oxygen, will go on way beyond 100. In fact, it will go to toxic levels of almost 300 millimeter of mercury at 80% oxygen, which is extremely toxic to the retina. Retina is very sensitive. And this is again way back in 1968. So if concentration of oxygen is high, that is the thing which should be reduced. So although we may not be able to prevent ROP in tiniest babies, and which is true, there is a role of preventing it in bigger babies by proper oxygen management using blenders. Like the previous speaker said, it should not go beyond 40%, and saturation should be less than 95%. And I hope in the future, when the iROP 4 again meets, they put in the word posterior, because it should happen only in the tiniest babies and not in the larger preterm babies. And this is an audacious goal. The final goal should be there should be a uniform single criteria for the entire globe. And why is that? Because babies born across the globe are all the same and they do not matter. And they should not become blind just because they are from the world of limited resources. And it's actually not limited, it's actually a little bit of our own inexperience and no lack of knowledge which is causing this blindness. Thank you very much.
Thank you, Parag.